We are very excited for today's presentation by Dr. Soske and Vanjani on compensating for system failures, the transformation of the community worker, health worker, peer recovery specialist roles during COVID-19. And a quick introductions on for Dr. John Soske, who is with the Lifespan Transitions Clinic and with our COBRACE Special Populations Core. He is a researcher with the Transitions Clinic and collaborates closely with the team of community health workers and peer recovery specialists. And Dr. Vanjani is a primary care physician and does clinical work with Rhode Island Hospital Primary Care and the Transitions and Recovery Clinics, where he also works closely with peer recovery specialists. And so they are well positioned to give this talk. So I will hand it off to you, both of you. Thank you so much.
Thank you, Michelle. Hold on just one second. Right. As we get started, we would like to thank the COBRA on opioids and overdoses and the Department of General Internal Medicine for financial support for this research, and Sarah Alavi and Hayoung Choi for research assistance. In some respects, our argument is pretty straightforward, and it's also not terribly original. I've heard versions of this argument made by community members and leaders of peer-run organizations over the last 6 months. But we thought it was important to bring these discussions together in one place and to elaborate the implications of this argument based upon some research. So here are the main points of our argument. The role of community healthcare workers and peer recovery specialists include resource brokering and systems navigation. Key resources are difficult or impossible to access, especially housing and healthcare, because of either systems failures or we would prefer the term market crisis. We believe that's a more accurate description of the situation that we're facing. This has resulted in an unacknowledged extension of the peer recovery specialist and community healthcare worker role with limited and insecure resources. And the way that people in our study have understood this extension of the role is compensating for systems failures. COVID-19 has intensified demands placed upon community health workers and CPRSs, creating a crisis across the Rhode Island CHW CPRS workforce. So a little background about the research this is based upon. What we're going to present today is based upon 21 interviews with community health workers or CPRSs between October 2020 and March 2021. And we used 2 inclusion criteria for people who we included in our study. The first one was that people had shared experiences with their clients. And the second is they are employed in traditional healthcare or mental health settings. So we excluded people who are working in peer-led and peer-run organizations. I should say a little bit about the decision to include both community health workers and peer recovery specialists. We did find that in some cases, these roles are still distinct and look quite different in different contexts. But we also found that there was a large middle ground where these roles bleed together. Some of this is intentional. There's been a push in the state to co-certify community healthcare workers and peer recovery specialists. But we also found a lot of more complicated dynamics. People who had been trained as community healthcare workers being employed in peer recovery specialist roles, people who weren't licensed as either, people who had moved back and forth between both roles, people working on teams of community healthcare workers and peer recovery specialists, all of whom were doing the same work. So there's a bifurcated landscape in the state. In some cases, these roles are quite clear and distinct, But in a lot of other cases, there's a very blurry middle ground. And I think we need to do more work to understand what's happening in that middle ground. This is community engaged ethnographic research. So this study, the larger study originated because we were looking into the work conditions and roles of peer recovery specialists and community healthcare workers after racism that our community health workers on our team had faced in a number of hospital settings. So this raised a lot of red flags, and we wanted to understand the situation better. So the community healthcare workers on our team both helped us in terms of study design and discussing preliminary results and the analysis that we're presenting today. And I want to make a final point about qualitative validity, or the validity of the kind of ethnographic research that we're doing. Qualitative researchers are often asked, all right, well, how generalizable is this? What is the external validity of your research? And I think that misunderstands what qualitative researchers are trying to accomplish in this kind of context. We're really looking at a complex community and trying to capture the experiences and views of a complex community at a particular point in time in a particular set of context. And that's necessarily going to be distinct. That's not necessarily going to transfer or generalize into another context. At the same time, if the research is done well, it should raise a set of policy questions and theoretical questions that might be more generally applicable. So we're really only trying to capture what was going on with a particular workforce in Rhode Island in a period of COVID, what people were thinking and feeling. We're not claiming that it's more general, but we do believe that the questions that this research raises transfers into other contexts and raises broader policy questions. So I want to start by discussing how the CPRS role is defined. And so this is taken from the state certification guide. A peer recovery specialist is an individual who has lived experience with mental illness and or drug and alcohol or other drugs, and provides one-on-one strength-based support to peers in recovery. So it's a framework of providing recovery support to people who are self-identified in a process of recovery from mental illness, substance use disorder, homelessness, incarceration, or family members of any of those groups. We pulled out the section that specifically talks about resource brokering in this role. One of the roles of a peer recovery specialist is to act as a resource broker. This means helping to identify and connect with social services and recovery supports in the community. If appropriate, accompany the peer to the program for the first time. And we included the final sentence because I think it really indicates the scale of the kind of connection and support that are imagined here. It would be pretty exceptional in our context if you were only taking somebody we were working with to a new provider for the first time, and that was sufficient. We have very little data on the peer workforce in Rhode Island. We know that there are 147 certified peer recovery specialists, but we're also aware that quite a significant number of those are not working. And this has been discussed at the state level as an area of concern for quite some time. Sarah St. Laurent was kind enough to share the one survey BHDDH has done with peers, which was an online survey conducted between July, August 2021. And we also wanted to thank Sarah for help throughout preparing this presentation. That gives us a little data, but that's actually a very small amount of data to go on. So I want to underline what we don't know. We have no idea how many PRSs are working in Rhode Island. It is quite clear that a number of people are working in peer recovery specialist positions that are uncertified and don't have any intention of being certified. We have no idea how many people working in PRS roles are licensed. We don't have any data on the distribution of PRSs across kinds of workplaces. We don't know the main responsibilities of their roles, the average length of employment, reasons for leaving employment, we have some rough salary estimates, but no data on salary benefits and workplace supports, and no comprehensive data on supervision, structures and practices. And critically, we also have no sense of the scale of returns to use, mental health crisis, or overdoses in this workforce each year. So there are a lot of questions and a lot of blind spots. The CHW role is defined as community health workers or frontline public health professionals who often have similar cultural beliefs, chronic health conditions, disability, or life experiences other people's in the same community. As trusted leaders, they often serve as a link between their community and needed health or social services. That's from the RIDO website. From the Rhode Island Certification Board, we took this description of systems navigation: assist people to understand and use the services of health providers and other service organizations, make referrals and connections to community resources to help individuals and family members meet basic social needs. And of these quotes, the word I want to pick out is understand, to help people understand these systems. And I want to come back to it because in many cases, that's actually not realistic. These systems don't make sense at a basic level. And that's something that's expressed in our interviews and that we hear from people both working within them and people trying to navigate them. We do have quite a bit more data on CHWs. There are two good quality reports produced by RIDO, one in January 2021, which is a survey of employers of CHWs, and a May 2021 report that includes online surveys with 68 CHWs that were collected from a mailing list of 300 that the Rhode Island Community Health Work Association had. The conclusions of this report are stark and quite realistic. It concludes that the report suggests that Rhode Island CHWs are at risk for not being able to meet their own or their family's basic needs. The report notes that this is particularly like many lower paid health services job, a gendered workforce. So it's often women who have people they're responsible for, and that puts increased pressure on already limited salaries. And I also think if you look at their sample, they have a more highly educated, better paid sample than the general workforce. They also note, as Rhode Island explores opportunities to sustain this workforce, it is imperative to explore the consequences of turnover for organization and clients, and the extent to which the income disparity and educational credential data reported in this assessment are contributing to problems with retention. One thing that's important to note about this report versus our sample is a very small number of people from this report were working in behavioral health or with housing. It was about 6%. And CHWs work in a wide range of roles. So there were people who were working in insurance companies with evaluators and people working in X-ray clinics. So we're really talking about a small segment of the CHW population, one that overlaps in practice with peer recovery support. And I just wanted to pull out the salary data, which is roughly consistent with the estimates that we have for peer recovery specialists. A third of the workforce works for $15 an hour or less. We know there are some recovery community centers that pay $12.50 an hour to their peer recovery specialists. 30% is at $15 to $18 an hour. And then about 25% is above this. Most CHWs work full-time. That's not true for peer recovery specialists. So these hour ranges don't represent full salaries, right? A lot of people are working part-time. And that means they're really working at the limits of being able to sustain themselves in Rhode Island. So I want to review a few standard assumptions built into these roles and the reality that our the realities that our interviews reflected. So and these assumptions in a sense obvious, and because they're so obvious, that's why they deserve to be questioned. So the first assumption is that referrals exist that can provide resources. And what we heard throughout 19 out of 21 of our interviews is that resources are often difficult to access or simply unavailable in the necessary time frame. The second assumption is there is a system, a housing system, a mental health system that is consistent and navigable for the CHW and CPRS for client. And that's where I went back to I'm going back now to pulling out that word, explain or understand. What we were told throughout our interviews was the system often appears fragmented, dysfunctional, and often hostile to clients. There's an assumption built into the role that clients in crisis should be referred to a higher level of clinical care, that there's a clear distinction between stable clients and clients in crisis. The reality from our interviews, and I would also say from our clinical practice, is that a lot of our clients occupy a kind of middle ground of low-level, constantly reoccurring crisis. People are not stable, don't have their basic needs met, are living day to day, but are not having the kind of acute crisis that would suggest referral to an emergency room or an inpatient situation like Butler. Complicating this is that a lot of people we work with have high levels of iatrogenic trauma generated by the healthcare system. So actually referring clients in crisis to acute care settings in some ways is the last scenario that we look at. It's sometimes necessary, and you always risk compounding existing trauma. And then a final assumption built into these roles is that there are clear boundaries between the professional workday and personal time. And what we found across our interviews, with I think one exception, and in multiple discussions in the transitions clinic, is clients frequently need after hours triaging, and CHWs and peer recovery specialists are constantly using a flexible approach to work-life boundary, taking calls in evenings, meeting people and taking to appointments on weekends. And originally, I think at the transitions clinic, we saw this through the lens of boundaries. Do people have appropriate professional boundaries? And then eventually in a discussion, someone basically said to me, I would much rather take a phone call at 10 at night than wake up the next day with my client dead of an overdose or reincarcerated. And it finally sunk in for me that we weren't talking about boundaries. We were talking about the way that the role was defined, and the fact that if our CHWs or CPRSs actually did the role as defined, they would be facing really significant trauma because they wouldn't be able to support clients that were in regular low-level crises, and those crises just don't map onto 9 to 5. We pulled this out of our interviews in terms of how community healthcare workers and CPRSs understand their role. And I'm not going to go through all of these. These were the most common ones across the interview. Sort of the full list of role definitions is three times as long. I'll pull 2 out that are significant to our later data, which is 1, meeting basic needs. Was identified across our interviews as a core part of the role, and then supporting recovery for peer recovery specialists or supporting wellness for community healthcare workers. One thing is the size of this list tells us it's just these are really complicated jobs, right? This is a lot of roles to fulfill at once. And actually to do this job well takes years of experience and training. It's not something one gets after a year or 2. But the complexity of the roles also speaks to skill level, which will speak to issues of compensation that we'll talk about later. This role list, I think, also speaks to issues of the danger of moral injury. we have built these roles around people's identities as members of community or people in recovery. And if we place these same people in situations where it is impossible to fulfill their role, we risk doing serious psychological and emotional harm. So we've created professional roles around people's identities and then put people in situations where it's often impossible to fulfill the professional roles. And that's a setup for high degrees of secondary trauma, burnout, and moral injury. A few qualifications before I hand the presentation over to Rahul. First is, I think it's really important to emphasize that, with one exception again, all of the people we interviewed found their work incredibly fulfilling. They are proud of these roles. They find them often the most meaningful work that they've done in their life. In the short term, they're willing to make these trade-offs for the opportunity to work with people who face the same challenges they faced. So everything we say has to be placed in the overall context that the people who do these roles really believe in these roles. I think that's important to say. The second is, of course, there was a diversity of responses across our sample. But it was largely a diversity of emphasis. So people who were working with groups that were stably housed had somewhat less a sense of acute crisis, and people who worked in context where there were highly structured teams designed to deal with high need situations like assertive community treatment. Those people also, there was a different tone to the interviews. All of the issues that we raised that we're going to talk about were present in these interviews, but I would say with less urgency. So that speaks to issues about supervision and supervision structure that we'll come back to. Finally, there were a small number of our interviews which didn't talk about systems crisis at all. I would say 18 of our interviews used the language that people felt they were compensating for systems failures. 3 of our interviews, people instead used the language of clients not being ready yet, lack of gratitude, not really wanting it, a moralizing language that placed responsibility onto the clients. And there was some overlap between these 2 sets of interviews. But I'm pulling this out specifically to be mindful of the dangers we face that when one's in a protracted space where there are no solutions, we can quickly find ourselves either blaming the clients or blaming the community health workers and CPRSs. And we saw elements of that in our interviews.
Thanks, John. I'm going to take over now and talk through some of our interview data in more detail. We're breaking these data down into 3 parts for you. Part 1, role shift, 2, COVID-19, and 3, continuing concerns. I'll begin with the concept of role shift. John previously provided the formal definitions of the peer recovery specialist and community health worker roles here in Rhode Island. It's important to recall that a substantial portion of these positions are characterized as systems navigators, or people who connect clients with existing resources. However, as John mentioned, 19 out of 21 of our interviewees explain that this is not, in fact, their reality. Rather, they consider their role as extending beyond resource connection and basic emotional support to actually compensating for massive gaps in our existing system. Peer-based workers in our state spend much of their time finding ways to meet clients' basic needs, not via traditional referral pathways, but rather via circumventing the existing infrastructure, a task that requires them to act creatively and to exert a great deal of emotional and often physical labor. In our interviews, there are 3 major themes that led us to the notion of role shift. They are systems failure, housing and mental health, and moral injury. Let's review some quotes highlighting each of them now. In many ways, this first quote summarizes our entire talk. John, can you read that for me?
Sorry, hold on. We're having a...
If not, it's fine.
Sorry.
No. Yeah.
We can see the quote.
Oh, yeah. You can read the quote, right?
Yes.
Okay, great.
Actually, we had Bethany offered to read it.
Oh, okay.
Oh, lovely. Thank you, Bethany.
That's
Bethany,
great. Bethany, would you like to do that?
Glad that you're here. Nice to see you.
Michelle, do you know how to recognize her so she can do it?
Can you hear me?
Yes. Yes.
Okay, beautiful. Our work is so all over the place. It's just show up to work, do your best, and take care of yourself. Because there's no clear path to work that we do because the system's so messed up. We come to a standstill where we can only do so much to get people set up for housing, and then it's a big waiting game. What lands up happening is you're just introducing comfort measures along the way, whether you're giving people a bus pass or giving them some food or giving them a hat. It's all comfort. After a certain point, there's nothing else we can do other than wait with the person and then be there for emotional support and helping them maintain connection to their service providers, doing crisis intervention. Our work is so all over the place. I cannot agree more.
Thanks, Bethany. We'll have to come back to you for some future quotes, so stay ready. I appreciate it. So this quote highlights the lack of a clear path that peer-based workers experience to answering most of the challenges faced by their clients. There are almost never any easy or direct answers to the issues being faced. Peer-based workers are constantly needing to improvise new solutions on the fly on a client-by-client basis. What this means is that it's hard and perhaps even impossible to define and understand the roles of peer-based workers. And the reason for this is simply our dysfunctional social system. A system within which our peers are asked to work under the pretense that it functions appropriately and efficiently, when in reality, our peers are telling us that it does not. The text highlighted in red here at the bottom of this quote is worth revisiting because it does a wonderful job of describing the unintended expansion of peer-based roles into crisis work. Often, a peer recovery specialist or community health worker is the only person a client may trust, and this can place these professionals in the position of providing a level of psychosocial support that's actually more appropriate for a therapist or psychologist to provide. For example, supporting someone in isolation as they describe prior trauma or as they sink deep into a depression places an immense amount of emotional pressure on both the peer-based worker and the client. Yet the reality is this is happening every day for numerous reasons out of the control of the peer-based worker. Bethany, would you like to read this quote? I can read it. Oh, great. Thanks.
Okay, thank you. Of course. Our systems fail people over and over again. It takes way too much time to secure the resources, which includes basic needs such as housing, so people don't have to do things like utilize emergency rooms or sleep outside. As long as basic needs are not met, what you end up having is a lot of people in their feelings all the time. You tend to deal with a lot of people coming at you sideways. Oh man, so much truth.
This quote highlights that while resources are sometimes in existence, the key variable is time. This brings us back to the emotional impact on both clients and peer-based workers of working within our system. Sitting with people as they wait and wait and wait is taxing and overwhelming for both the clients and the peer-based workers. While failures across our social system run quite deep, the two most prominently featured aspects of the system that were brought up throughout almost all of our interviews were housing and mental health. So I'd like to share a quote about that here. Bethany, if you don't mind.
The things we can't do as a community health worker would be housing and finances. Also mental health needs. There's not enough services for what these patients need. A lot of times I feel like that it's a system thing, and it's not so much our job thing. I wish there was more help for that.
As a provider at the Transitions Clinic, I see this on a daily basis. No matter how competent our community health workers and peer recovery specialists are at doing paperwork, such as housing applications, with their clients, and picking up the phone and making referrals to mental health agencies, the barriers to housing and mental health engagement run exceptionally deep. In fact, they run so deep that often our peer-based workers begin to feel that homelessness and lack of attention to mental health are inevitable, and that their time is better spent on other tasks, such as simply sitting with clients and bearing witness to their lives, accompanying them to court, reactivating SNAP benefits, etc. It can lead to a nihilism of sorts, both among peer-based workers and their clients. Let's talk about moral injury. Bethany, would you mind reading this quote for us?
Of course. That leaves me to go home feeling bummed, because I don't know what kind of phone call I'm going to get tomorrow saying that he died when he was just on the phone with me begging for help, and then I couldn't give him none. I got patients sleeping in a storage unit, dead smack in the middle of winter. You know what I mean? Those are low points for me. Sometimes I don't even want to go home because I know what I'm going home to, and I know what they're.
One more, Bethany.
Sometimes you do feel useless, and you take it personal as like, this is my job and I'm helping them. But what is 6 months housing waiting list? What is that really going to do to someone? You feel useless sometimes. I wish we had the power but we just don't.
We have to acknowledge the scale of the toll that this places on peer recovery specialists and community health workers. In particular, what we're asking of these professionals is to, in essence, help clients rebuild trust in our social systems. However, in reality, what they're doing, and they know this and articulate this, is they're compensating for the failure of these systems. A helpful example from our work in the Transitions Clinic and my work as a physician is to consider the community health worker who visits a client while they're hospitalized at Rhode Island Hospital. The community health worker's job is to serve as a bridge between the medical team and the client. If the client becomes upset or frustrated with the way in which they're being treated, for example, their room is searched for paraphernalia while they're away at the CAT scan, the CHW's success is measured in terms of their ability to talk the client down and keep them in the hospital when they become angry upon learning about the search. This places the CHW, who has perhaps been in a similar position as the client before, and who understands how our health systems can fail people and prematurely judge people, to act as a representative of the health system, because the health system alone cannot meet the patient's needs. If it's up to the health system alone, the patient will leave against medical advice. So the CHW steps in to patch the broken system, to keep the client in their hospital bed so that they can receive life-saving treatment that they would not have had the CHW not been there. When the CHW goes home that night, all they can think and talk about is the trauma that their client faced in the hospital that day, in an environment that is supposed to be therapeutic. The CHW's family worries about them. The CHW has difficulty sleeping, knowing that their client could leave the hospital at any point overnight if they're disrespected by hospital staff. So we risk putting people in roles that they can't fulfill. We know from a lot of research that the type of injury that this can do, especially when those roles are connected to people's identities, as they are with community health workers and peer recovery specialists. This is a key point. Every provider knows there's a limit to their role. This isn't unique to the peer community health worker. However, the difference is that when a peer or community health worker has discharged someone from their panel or has to leave someone in the hospital overnight after a rough day, it may feel like they're cutting someone off who's going through many of the same things that the peer went through themselves. Or it may feel like they're cutting someone off from their own neighborhood or family, and this confers a substantial amount of moral injury. Next, let's talk about the COVID-19 pandemic. The role shift we've just described was happening before COVID-19, but it's been hugely intensified by the COVID-19 pandemic. To capture this, we're going to review the last year and a half that we've collectively gone through, and which can certainly be difficult to hear for many of you on the conference call today. And so I want to preface with this warning that we'll be diving into some of the data of the last year and a half. So as you all know, prior to the start of the pandemic, we began to see overdoses rising in Rhode Island. And in March 2020, advocates and national news coverage began to warn of increased overdoses with working remotely and social isolation. And then in July of that year, RIDO convened the first open meeting with our community partners to discuss the rises in overdose deaths and possible responses. Bethany, would you mind?
I do not mind. What a lot of people don't understand is that we were not only losing clients, we were losing coworkers and friends in our recovery circles at the same time from both overdoses and.
And this quote clearly highlights how the moral injury that peer recovery specialists and community health workers were facing prior to the pandemic was greatly intensified by the pandemic. What compounded this situation was unplanned shutdowns. As you all know, there were shutdowns of in-person mutual aid meetings, and many of those meetings tried to convert to being virtual in nature, which meant that certain people could access them, and for others, they were completely inaccessible. There was a reduction in substance use treatment beds and shelter capacity due to COVID restrictions. I personally served as the medical director for the state's COVID-19 isolation and quarantine hotel. And during that time, I was acutely aware of how difficult it was to get people who had been diagnosed with COVID and completed their isolation back into shelters or substance use treatment facilities because of the diminished capacity. And so we had to at times discharge people to the street, and those people were sick. And that was one of the hardest things I've had to do. And of course, those people were accompanied by their community health workers and peer recovery specialists, making that journey particularly difficult for those professionals. There were a few backups in place for people who couldn't transfer to telehealth or who struggled with technology. And again, as I mentioned earlier, there was this fragmentation and lack of coordination that resulted in inconsistent guidelines. As we attempted to transition people during COVID into various detox or residential treatment facilities or recovery houses, it seemed like each agency had its own guidelines and criteria for accepting people back, and that made it exceptionally challenging. And this obviously all occurred in a context where we were seeing an unprecedented increase in return to drug use, mental health crises, etc. Bethany, I think this is the last one.
Okay, it's okay. In our position, we never did not leave work. We stayed going out to the streets right through COVID. We did have options to do remote work as well, but in our position as outreach managers, we were actually some of the only ones that were visible while all the other places were closed. And people were confused and needed more help because it created that much more anxiety amongst the masses.
And this quote reveals a similar sentiment that people, peer recovery specialists and community health workers who were working during COVID felt like they needed to stay out in the community because there was nothing else left for their clients. And so the last thing they wanted to do was say, listen, I'm working from home, that they couldn't think of anything that would feel more isolating for their clients. Bethany, one more.
Okay. When COVID hit, I was working at blank. I used to come in the office and make phone calls. I just remember how hard it was for everyone who used to come in and do a meeting. We tried to do it virtual, but it wasn't really the same. And I saw a lot of people relapse. Some people pass away. It was a hard time. I seen how it was affecting the peer recovery specialists. There were a lot who had to take some time off. It's tough. It's mental. Not being able to provide support, it's different than face-to-face contact. Not being able to see them in person, I still remember how overwhelming it was at the time. It was difficult.
So I'll conclude and pass it off to John with this quote that I think really summarizes well the impact of COVID on this workforce. We posed this question to all 21 people we interviewed, and every single person said no.
All right, so drawing on this data, we wanted to note some warning areas. First is, you can see from this the possibility of a crisis developing amongst the peer recovery specialist and community healthcare workforces across Rhode Island. Subsequent to our research, Michelle McKinsey for RIDO did 4 focus groups with harm reduction outreach workers between July and August 2021. What's notable is this is a different population entirely from those that the people we talked with in our interview, and the themes are remarkably consistent. So housing is a major theme, lack of affordable housing, shelters that report harm reduction, recovering housing from transgender people, lack of housing for people with severe mental illness, SUD treatment. We still are in a situation where there are inadequate beds and residential treatment availability for substance use disorders. The amount of people's time that is spent addressing basic needs. Outreach workers report spending much of their time and energy navigating systems, especially with regard to housing and other basic needs, to futilely. And then finally, the theme of trust. The inability to provide referrals that people can follow through diminishes their trust. For the sake of time, I'm going to skip this. And then by thinking some about the dangers of exploitation regarding this workforce. Again, I want to say that despite everything we've laid out, people love this work that we interviewed. They find fulfillment in their roles. This work is meaningful. They see it saving lives and making a huge difference. But to return to what we said before, average compensation is $17 or $18 an hour. These positions are grant funded, therefore they're temporary. So there's both the stress of having a temporary position and the constant stress of if you fail to meet grant goals, your position might disappear. There are huge variation in terms of benefits. There's an advancement ceiling. There's not much in terms of senior peer recovery specialists. So the role is limited. And with at least half of our sample, people told us that they were less well off doing this work than they were when they were on SSI and Medicaid. They actually struggled to meet their own basic needs and spent more time struggling to meet their own basic needs when they had state benefits. So I think it's necessary that we start talking about the potential for exploitation in this workforce. Are we creating a low-cost, general-purpose social service workforce, drawing on populations that are vulnerable to stigma and exploitation? At an individual level, our participants saw this as a worthwhile trade-off, at least for the short term. So they really saw the wages insecurity as being a worthwhile trade-off for how meaningful the work is on a day-to-day basis. But at a systems level, we should be concerned about the ethics of asking people to make this trade-off and the implications of creating a workforce whose political economy relies on this trade-off. So we have two sets of recommendations in conclusion. One relates to role clarification and the other role support. And for this presentation, we want to focus on role clarification because that's the overarching theme of our talk today. So the suggestions we offer for role support are more tentative and will provide sort of more specific recommendations once our data analysis is completed, but we wanted to put forward some things. So I think the first recommendation is that we have to acknowledge and address that the roles of CHWs and CPRSs have been extended and transformed in the context of our current crisis of housing and mental health markets. Telling the truth is the first step. Sometimes we say that in recovery. I would say that's also true for the discussion about where to go next in terms of thinking about how to best support people working in these roles. During COVID, there was some effort, and I was part of this, so this is self-criticism as well, to offer people increased supports for the stressors that they were facing. So we set up new support groups. We created drama therapy groups. And I do think this was important, but what our peers were saying to us was that they were struggling to find people housing and mental health. So instead of listening to what people were clearly telling us was producing the increased stress in their work, in a way we put it back on them by suggesting, oh, navigate this crisis through self-care, versus instead we should have been joining and linking, we should have been offering both increased mental health support and increased institutional support. And I want to stress too that role clarification is not just a verbal question. I can understand a sort of impatience, which is people are underpaid, they don't have benefits. Why are we sort of mucking around in the abstraction of these definitions? But I think it's important to emphasize that the infrastructures for supporting these roles have to be based upon an accurate understanding of what this work actually entails, what people are doing in reality. So our ethics infrastructure, our supervision infrastructure, our work-based supports, our training, and our compensation infrastructure have to start with the reality of the work that people do. And instead, what I would say is we're seeing an increasingly large divorce between the infrastructures we built around our ideals of these roles and the reality of how people do these roles and practices. And one danger of this disconnect, of course, is simply people don't get the necessary support they need. But the other definition is you can see us sometimes sliding into blaming CHWs and CPRSs themselves for how they're compensating for this situation. For example, numerous contexts I've seen supervisors tell CPRSs or CHWs that they are overstepping the role or being unethical because they're accepting phone calls at night, or because they're providing deep emotional support and counseling to people. Versus in reality, for many people working these roles, they would be next to impossible to do if CHWs and CPRSs weren't, quote, overstepping the way that the role is defined. So if we don't come to terms with the reality of the role, we risk, in fact, putting the responsibility for the system's failure on CHWs and on CPRSs themselves.
And I think at this point, because it's 12:27, we'll leave you to read this slide. And as John had mentioned, really our main conclusion relates to role clarification. And with just a few minutes left, perhaps we'll open it up to questions.
Michelle has agreed to stay on for a bit, so that we can talk as long as people have questions or would like to.
Yeah. So thank you both very much for that presentation, and it is a lot to take in. And we can make that available for folks. Is that right? Yes, great. So that is great. We'll make it available to folks. And John, Rahul, and several of us are available. We can keep this line open for another 30 minutes, so people are welcome to ask questions. I do want Obed Pat put a question in early on in your presentation about how many CPRS or community health workers are Spanish speaking. Do you have a sense?
A minority. So there's no data on that.
Okay.
You know, I personally know a handful, but it's definitely a minority of the workforce. The CHW data we have is that the workforce is overwhelmingly white. And so that, of course, is a significant issue. Steps have been made to try to diversify the CPRS workforce and recruit more Spanish speakers. So people are aware of this and are working on that. I don't want to make it sound like people are ignoring the diversity and inclusion issues. I think people are very aware of that. I think it's also difficult to attract people into the roles for the reasons we've laid out.
Yeah, that's right. John and Rahul, can you see the chat? I just wanted to let you know that throughout your presentation, there were a number of comments of how on point your observations and your reporting here is.
We're reading it now. Thanks.
Okay. And then if folks have questions, they can raise their hand or put it in the chat. Colleen has her hand raised.
Hi, yeah, I just wanted to thank you both. I've never felt so seen in my life than listening to this webinar. I just felt like it was absolutely incredible. I wanted to respond actually to Obed's point, which is something that really bothers me a lot, is the restrictions on CPRSs, the GED requirement, requiring people to take tests, things like that. We have a number of people who have done the CPRS training, are Spanish speakers, do not have a GED and can't get their GED, or they will fail the test multiple times. And there's a sense of that is a barrier for folks, and those are some of the best folks doing this work. And so I feel like I've brought that up several thousand times, and I don't know, I think it goes all the way to the national people. But I still feel that that's something that we really need to address if we want to diversify the workforce, and if we want to get folks with lived experience. We can't have these unnecessary barriers.
Colleen, we have experienced that too among our community health worker peer recovery specialist workforce, and completely agree. And that last slide that we skipped about support, I think what we could have done in place of that slide is just inserted any of the speaking engagements you've given where, and that's really been your talks about how to support peer recovery specialists and community health workers. Those points really came out during our interviews. And just to sort of recap what you often say and sort of the ethos we subscribe to is that when working with peers and community health workers, it's important to think about where strengths lie and to create a support system where we can help people to flourish where they have strengths and help support people where there may be weaknesses, whether that be, on computers or with test taking or whatever else. And so that's part of the reason why we feel like having a robust support system is so important. And it's what you all do so well at Weber Renew, is that we're really trying to customize how we support each professional on a case-by-case basis. And so to think that we can just hire a huge workforce of people and sort of let them go out into our broken social service system without giving them that time of customized support is perhaps a little bit misguided. So thanks for that. And I just wanted to give you that shout out.
Bethany, did you have a question?
I just wanted to say every single word that has been spoken today, I've either thought, felt, or heard from other CPRSs. I absolutely love and respect the fact that this is finally being put in the spotlight, and that, like the woman before me just said, I feel seen as well. I mean, thank you very, very much. And if anyone needs any.
Oh.
Are you there?
Yes. No, we just the last bit, Bethany, you got cut off.
I was saying that if you all need any help or any information on experiences or barriers, I mean, literally anything, I would love to be a part of this change, because this is a long time coming. And
Thank you. And I do want to point to the comment in the chat. They have to leave soon. It's from Rick around supervision.
Yeah, to respond to Rick's comment, which I think is really interesting, I think a lot of creative thought needs to be put into supervision. Most of our interviews showed that the current state guidelines for supervision, which are 4 hours a month by people who have gone through 3 hours of training to be supervisors, are one, inadequate, and then two, rarely adhered to. So the number of places that have strong supervision support systems, I would say, are the exception rather than the rule, though they do exist. I think we need a lot more in terms of centralized support for peer recovery specialists. I think Sarah St. Laurent is doing a great job at BHDDH, but apparently from the outside, it looks like with very limited resources. And they're just very straightforward empirical questions that we need answers to. And we just don't have data on this workforce right now. And I think one idea I hear from peer recovery specialists frequently is the development of some type of union or some type of professional association. So there is a peer recovery specialist board at a state level that does some good advocacy for peer recovery specialists with BHDDH and with the state. However, it's a board composed primarily of people who are heads of agencies that are employers. And so while in some respects they're well positioned to represent peers, on another hand, peers also need representation and advocacy vis-a-vis their employers. So I'm not suggesting that be displaced. It's quite a useful venue. But what I've heard from peers repeatedly over the last 2 months about talking about these findings is our ideas like a union.
Great. We have a question from Amy Hope, and it's our CHWs in Rhode Island and all Rhode Island hospitals. As a CPRS, Amy often encounters individuals in the EDs in the middle of the night and on weekends who are in need of both community health workers and PRS support, but only meet with PRS because social workers, behavioral health clinicians, et cetera, are on call and they're not called. And she often feels these patients are slighted and would greatly benefit from networking with a community health worker or a CPRS, or community health worker, she says.
And this is a perfect example of what we're saying about role expansion. So if a CPRS shows up in this instance and they have a patient that needs a social worker or a CHW in the middle of the night, they're posed with a dilemma. Do they stick within the strictly defined boundaries of their role and essentially tell this patient they can't help them? And then they become one other example of the system telling these patients to go fuck themselves. Or do they overstep their role and start doing the work of a CHW or social worker, but then that's additional work, that's with everything that goes on to that. So it's like almost a kind of blackmail that the system is placing on people. Stay in your role and therefore accept that you're going to fail people because the supports don't exist, or overstep your role and do what's really necessary, but you won't be adequately supported or compensated for this decision, and maybe even blamed for it.
I would like to just sort of emphasize what John, you suggested, that how much overlap there is between the interviews that you conducted and the focus groups that we did. Now, we very specifically were working with folks who are doing direct service harm reduction, and so it was a different group. But with regard to not having access, that the referrals constantly running into the systems not being adequate to the needs of the clients came up. We had 29 people participating. It came up repeatedly. So it just supports what you have brought, wonderful information that you brought in the conversation today. Oh, Ian.
So thank you for this like groundbreaking perspective and information. Two of your statements are really just smacked me in the head. The fact that the reality that folks have to overstep how their role is defined in order to do the work, and the inference that the infrastructure is not based on the reality of what people do, strongly suggests that the training is inadequate. Is that correct? And what do we do about that?
I would say the current, I haven't been through the CHW training. I went through the CPRS training and then offered it, was a co-facilitator for it. for about a year. And I would say, yeah, there is a disconnect between training and reality that we need to look at.
I think this really been a phenomenal presentation, and really I learned a lot, and have a tremendous respect for all the hard work people are doing, and we really have to figure this out, how to get this workforce tapped. And I agree that having a GED is not necessarily the requirement. On the other hand, and also it's critical that the training. And if you have some levels of training and, sort of professionalize this, then there are going to be things that people are going to want to know. One of the things that jumped out at me early on was this, there's a pervading sort of 12-step attitude that against the use of medications. And yet we know that medications are critical for people with opioid use disorder. Without methadone or buprenorphine, there's going to be a lot more deaths. And in our state, we have really been lackluster in the rollout of buprenorphine. And I think that's, part of that is on the medical system not making it widely available. And part of it is on people's understanding of what it does and what its role is, and not taking advantage. And some of that is coming from messaging about that you're not really, in recovery if you're taking medication. So, and people don't want to, they feel like it's a liquid handcuffs or it's a burden somehow, which, it is a burden. But the question is compared to what? And so early on, I was very concerned that, people are if people are in crisis, they come to the emergency department, the peer recovery is called, the physician says, oh, well, you should start taking these medications. And then the peer recovery specialists who they have, trust, they say, well, what do you think? And they can get influenced one way or the other. And so I think it's, it's sort of, if we're not educating our peer recovery specialists to understand the role of medications and perhaps other interventions. But I mean, that to me, that's the clearest, most obvious thing that we should really be focusing on. It has a limited role. It's not going to give people housing, and it's not going to address all the other psychological trauma, but it's going to keep them alive and give us time to work on everything else. So I guess my question is how do we professionalize that, and how do we turn this into a professional role and develop levels of expertise and knowledge?
So I know Rahul has thoughts on this as well. I think there was a sort of sub-analysis in our presentation that I skipped over because of time length about the CPRS role in particular. And I think in the state, we're in a transition between an older definition of the CPRS role as essentially a recovery coach with a fairly coming out of a 12-step and CCAR tradition. And I come out of that tradition. I'm in 12-step recoveries. It's nothing against 12-step recovery, but it's a particular idea of what the role entails. You work with somebody in self-defined recovery to articulate and work towards recovery goals. And at a more systems level, we're asking people trained basically in this framework with some adaptations, but trained basically in this framework to work as harm reduction workers. And within the CPRS workforce, you're seeing a lot of debates over this. And sometimes it's a harm reduction versus recovery debate, which is a false dichotomy, but it's a debate that exists. Sometimes it's a substance use disorder peers should not be working with mental health or homeless people debate. So this is a whole other set of issues specific to the CPRS role that we didn't get into, but I think we're in this midway point of a transition, and we're not talking enough about the transition, and moreover, we're not necessarily working the transition through with the people who are were already doing the role and who still have an older style approach that sometimes isn't helpful. I will say about the rollout of BUP, and this is something that Rahul and I hear a lot about patients, is when it looks like we're offering buprenorphine instead of addressing people's social and structural determinants of health, it feeds into a kind of medical mistrust. We definitely hear some version of like, I need housing. Why are you trying to give me drugs? Are you a doctor fronting for the pharmaceutical companies? Like, so while I do agree with you about the importance of doing much better in terms of deploying BUP, I also think that if we divorce it from meeting people's basic needs, we actually might be producing resistance grounded in deserved medical mistrust. But Rahul has been thinking a lot about this.
Yeah, and that's also where, Jody, I share your sentiment. And I think there are other pathways to getting there that sort of circumvent the medical mistrust, one of which is just greater collaboration between physicians, peers, and others. So while one approach is to really build the competency of peers and community health workers to understand buprenorphine, understand when to counsel people about it, understand when to encourage people to get onto it, I think if we're doing that in parallel, we should also be strengthening relationships between, Weber Renew's peers and all of the healthcare providers that work in the surrounding areas. And the reason I say that is because, as you know, and as I think many of us know, taking the example of like antipsychotics for someone who's labeled as having schizophrenia, it can take like 2 to 3 years of building trust with that person to convince them that we'd like to start them on an antipsychotic. And at least in the case of us in the transitions clinic, that's happened in a few instances, and it's been incredibly beneficial for the patient. And the only way it's happened is through collaboration between a physician, a peer, and a patient. And so while I feel like building that competency is important, I think we should equally work on figuring out how to have more collaboration between our community-based organizations and the healthcare sector. And I think that's practically really difficult to accomplish, but probably possible. But I would say if we did it in isolation, Jody, could it paradoxically cause a little bit of harm? Like if we just force that education upon peers and community health workers without that collaborative piece. And I don't know.
Well, there's
okay, Dave.
I mean, there's just, it's, some of it is just simple information, just understanding, that medications aren't recovery. There's nothing better to reduce your risk of overdose death. So, so that, they have a critically important role, but not a, they're not recovery. Don't mistake, oh, I've taken my pills and I'm good. That's not the message. But translating and making sure that, the peer recovery person says, well, the doctor's telling you to get on this medication because they're worried you're going to overdose and die. They don't care about the profits of the pharmaceutical industry, and really translating that into, just providing information from someone they trust. Sorry, Michelle.
Kelly Walsh has a question or comment.
I know I joined late, so I apologize. I was busy, but thanks, guys. I really enjoyed listening to what I did here. Being a peer that works in the ED, and I actually came from working in a community-based center before I joined the ED, and I worked on an MAT team and as a community health worker in that team as well. And I'll tell you, like I learned a lot in all the roles. And so I understand what you're saying, Dr. Rich, as far as, it's a medication, it's harm reduction. And I also am part of a 12-step. I came from 12-step based as well in recovery, so I understand where you're saying, John, as well, being 12 steps and, you know, the whole peer cycle. And I think it's just about learning and educating ourselves and being comfortable as a peer in our own ways of what we're comfortable, you know, teaching ourselves and what we're comfortable as being a peer in this role in educating, you know, and how are we comfortable in the ED or in the community and learning within, you know, everybody. You know, I just think it's going to take time. Doesn't happen overnight. You know, I do a lot of work in the ED that a lot of, like, I know Amy had said, you know, I do a lot of housing applications. I do a lot of help people with food stamps while they're in the ED. I connect to social services. I make appointments for people. So I kind of veer outside of my lane as a peer recovery specialist. I don't just necessarily say, hey, this is, you know, what do you want? What do you need? I do a lot of social determinants of health as well. So, you know, I think we all need to be kind of become community health workers with the CPRS. So, Ian, to learn about PUP and MAT, anybody can go on and take the waiver training to get more educated on that. You know, you don't necessarily get your waiver at the end, but it can be very helpful to learn about the medication side of it. You know, that's my own opinion. Just listening to the whole thing. I mean, you know, I knew nothing about MAT when I first started. I came from a 12-step program where you stopped cold turkey. You know, that was my thing. Now I am a big advocate for MAT. It saves lives, but it also doesn't cure everybody. You still need to do other things to take a medication. You still need to, you know, do meetings, or you still need to do therapy. It doesn't necessarily mean we are fixed. We need to learn coping skills, still relapse prevention, triggers, you know. So there's a lot to it.
Thank you, Kelly.
I really appreciate what Kelly said. And I do want to address one thing that I was going to talk about in a skip slide, which is, and Kelly's right, one solution we could propose to this is that everybody becomes dual certified, and being a peer recovery specialist is sort of like a skill set within community health workers. I think what we're seeing in practice with peer recovery specialists right now is they're often being tasked to work with people who drug use might be one of their problems, or mental health issues might be in the mix of their problems, but it's a really complex mix of housing, employment, criminal justice history, that they're really struggling with their social and structural determinants of health. And the substance use is mixed in with this, but it's not somebody who has a substance use disorder and is in recovery from a substance use disorder in the model that we typically think about it in the peer framework. And it does raise this question of when should peer recovery specialists be working with people in active SUD or active mental health crises? And a lot of peer recovery specialists will say, for very good reasons, that's actually not my role. That's a clinician's role, or that's, you know, we get into a certain risky ground when we ask people, especially in early recovery with relatively limited training and support, to work with a client caseload that consists of significant number of people who are in the midst of active use. Mm-hmm. So I do think there's, I think we are integrating the community health worker and CPRS roles, but I do think there's this way that the CPRS role could just get swallowed in terms of what's a general low-paying social service role. And I'm worried about that. I think we should actually defend the CPRS role, but use it in a more targeted, deliberate way. But I think there's a lot of room for debate here. There's certainly a lot of different views amongst peer recovery specialists on this. I think Rahul's and my point is just we need to have this conversation in a more organized way than we're having it now.
Bethany, you had your hand raised. Did you want to have a question or comment before we close out?
I just wanted to have one comment. Well, for one, John, you kind of already just said what I was going to say. Thank you. But also, I do want to just reiterate one thing that I've been through Connecticut and Rhode Island CPRS training, recovery coach training, and they all have the same thing, that the same key is meeting someone exactly where they're at and multiple pathways. There's no cookie cutter way, right? And I personally, in my own recovery, I have utilized 12-step, medically assisted treatment, spirituality. You know what I'm saying? I have tried so many different things all while in recovery. And so being a CPRS, I cannot limit myself to what I have done. I cannot limit my peer to what I have done. That is ethically very wrong. So in the trainings, it's always the same. It's always basically open your mind, learn about new things, offer these new things. So although I agree medically assisted treatment works for some people, so does a 12-step for some people, but not other people. You know, it's such a variety. And just know that we are very much so ready and willing to try new things with these people that need it, you know? So we're not shut down to it. We're educated. We are always open for more learning. That's all I have to say.
Thank you, Bethany. I'm just going to highlight what Amy's question, because it speaks to this dual certification that you mentioned, John. So folks who've been doing the work for a while and could be potentially dually certified, but there's a barrier, and Amy lists a considerable barrier around certification and additional hours. And I'm just throwing that out there and what you guys think about that, and if there's a way to address that through grandfathering or something, testing, I don't know.
I mean, I don't know that I have an answer to that question other than to say, I think bringing together people from the Department of Health like Deb Garneau, and then people from BHDDH, and then the Rhode Island Community Health Worker Association, and Parent Support Network and other places to have that discussion in like an integrated and coherent way would be really helpful. Because I'm sure people from all of those organizations have thought about this, but perhaps there haven't been as many opportunities to all get around a table and discuss together.
And part of this is due to the fact that peers fall under BHTDH's supervision and community healthcare workers fall under RIDO's supervision. So we're creating a joint workforce. We have a workforce that actually a lot of people do both jobs, whatever titles they have. We have a lot of people out there doing these jobs that have not gone through any training. And yet we have an administrative structure located in 2 agencies. So that's an obvious systems gap we can start talking about today.
Thank you. Well, it's 1 o'clock, so we're going to close now, but thank you both so much and for all of the amazing participation and comments today. So thank you.